symptoms, the numbness and tingling. Other helpful tests to evaluate for people that come in with these complaints are x-rays of the neck. And the reason for that is that the nerves in the neck coalesce and form the carpal tunnel nerve, the median nerve. So you can have a pinched nerve in your neck or an arthritic spur in your neck putting pressure on the cervical spine nerve roots, which mimic carpal tunnel syndrome. So one of the most commonly misdiagnosed conditions with people that are present with carpal tunnel syndrome is a cervical arthritis with the radiculopathy, where the nerve is pinched in the neck. Obviously, we like to get x-rays of the hand and wrist. Sometimes there's calcification within the carpal tunnel from people that have pseudogout or other conditions that can cause pressure on the nerve. Probably the most helpful test is a nerve conduction study, which basically evaluates how the nerve is conducting its electrical impulse across that area where it's compressed. One of the other findings are thenar atrophy. People that have long-term carpal tunnel syndrome, this muscle actually wastes and sometimes completely disappears, and that affects their function because they can't oppose the thumb to that small finger, as we talked about earlier. Again, this is just to reiterate what we just talked about. Arthritis in the neck, arthritis in the hand can also cause similar problems. Circulatory disorders such as Raynaud's phenomena certainly mimic carpal tunnel syndrome, but it's not causing it. And a trapped nerve in the inner elbow, the ulnar nerve in the inner elbow, people present with numbness in the hand, but it involves the small finger and half of the ring finger, that ulnar nerve, the other major nerve to the hand. So that's one of the more common symptoms that people present with that think they have carpal tunnel but don't. Another physical exam is what we call the Tinel sign, which is just tapping the nerve at the wrist, and this produces an electrical shock that goes into that nerve, the distribution of the nerve into the fingers. Let's get into treatment. And there's two treatments, the non-surgical and the surgical. We always like to exhaust the non-surgical treatment prior to embarking on surgical intervention. The non-surgical treatment includes splinting, as we mentioned previously, which is just a wrist control splint with keeping the wrist in a neutral position. Medication is also helpful to decrease some of the inflammatory reaction within the carpal tunnel, non-steroidal anti-inflammatories such as Advil or Aleve. A cortisone injection is also a very helpful treatment early on, where you're decreasing the inflammation by injecting a cortisone preparation around the nerve. And obviously treating any underlying pathology such as diabetes or thyroid conditions or gout is very helpful in treating carpal tunnel syndrome. A lot of the time the symptoms go away when the underlying condition is treated. Here's a wrist control orthosis. This has a thumb spica component, but this is basically what we're talking about, keeping the wrist in a neutral position. Other associated treatments that people use are vitamin B6 that you might have heard people use, and basically vitamin B6 is helpful for people that have vitamin B6 deficiencies, which we don't really find too often in the United States. But it's gotten popular, people treating carpal tunnel syndrome with vitamin B6. The problem with vitamin B6 is at too high a dose, it's actually injurious to it can injure the nerve. So we like to, if we're going to try the B6, we'd like to keep it at 50 to 100 milligrams and no more. Diuretics. Diuretics are basically used to decrease some of the fluid retention, and it's not a real conventional treatment anymore. It used to be more conventional prior to some of the current treatments that we've developed. Obviously, avoiding the activity that precipitates the condition, splinting the wrist, the anti-inflammatories, and local steroid injection. These are all the typical treatments that we try to employ as a conservative option. The surgical treatment basically is taking the pressure off the nerve by dividing the transverse carpal ligament, that structure that we showed early on. And there's two ways to do that. One is with the conventional open technique, where we make an incision in the palm, and we're basically dissecting down to expose that ligament and just cutting that ligament. Cutting the ligament obviously opens up the roof of that carpal tunnel and allows for the pressure to be removed from it. That ligament will actually heal back, but heals back wider. There's a newer treatment that we've been using for the last 8 to 10 years called endoscopic carpal tunnel. It does the same thing. It's basically less invasive. You're making a smaller incision and you're just cutting that ligament without